Hello, friends. Today, my topic will be on medical disorders in pregnancy. I'm going to deal with thyroid disorders today. Thyroid, as we know, can function less than normal hypothyroid or more than normal hypothyroid. When you compare the incidence of hypo and hyperthyroidism during pregnancy, hypo is relatively more common compared to hyperthyroidism. So, what should we know about hyperthyroidism? Mostly, the patients who have hyperthyroidism, they have been diagnosed and they're already on treatment before their pregnancy starts. This is a pretty great thing. Some of the patients who have not been diagnosed were diagnosed for the first 12 days of pregnancy, which is quite rare. What is the commonest cause? It's always in women. It's autoimmune. Thyroiditis, especially Hashimoto thyroiditis, is the most common cause for autoimmune hypothyroidism. We should also consider any previous surgeries that the patient will have undergone thyroidectomy, exposure to radiology, or have taken drugs like amiodarone and lithium. Clinical features, we know a good number of clinical features, but the most these two features, the patient is usually in history of cold and tiredness. This is very, very important history. In examination, always from bradycardia, reduced heart rate, and slower relaxation of the tendon reflexes and culture. Diagnosis in hypothyroidism, the thyroid stimulatory hormone is increased, and there is a reduced level of free hormone, thyroxine. It is of the male principal point in the diagnosis. In the first trimester, they look into the free level of thyroid hormone FT4, which is reduced. The second and third trimester will go by the TSH levels. TSH should be within the normal limits. So does this pregnancy have any effect on hypothyroidism? No. But hypothyroidism affects the pregnancy in multiple ways. Like if you have a patient who is young, who is just married, not on drugs, she will have anovulation. So when it's difficult for the patient to conceive. Second thing is, even though she conceives, she will have repeated miscarriages, abortions. She may suffer from preeclampsia, increased blood pressure during the pregnancy. She may deliver a low birth weight infant. She can have diabetes during her pregnancy, and the baby born of hypothyroid mother has a low IQ, poor nutrition. So this rule, always the golden rule is always aim for optimal control of the patient before getting the patient pregnant. Before a patient with hypothyroidism becomes pregnant, she should be adequately controlled with drugs. How will you manage? The patient is already taking thyroxine, or she doesn't have any other symptoms. The biochemical values are within the normal limits to continue with the same dose. For newer patients, we start with 25 to 50 micrograms and then repeat the next up to 4 to 6 days to adjust the dose. Levothyroxine. This hormone is absolutely safe during breastfeeding. Now, looking to the bomb abuse, normally the TSH thyroid stimulatory hormone is expressed in a new paritha at its 0.3 to 4.2. And the FT4 free level of thyroxine is expressed in picomole. It is 1 to 26 picomole. So what is the ideal value of the TSS.T4 during the 3 trimesters? The first trimester always aim for a TSH of 5.5. The second trimester 3.5. Third trimester 4. As FT4, first trimester actually 16. Second trimester should be 15. And third trimester should be 14. So this is potentially my goal, which we are going to achieve. The question is, when did with hypothyroidism? Also, this is all about hypothyroidism. Now I am going into a second topic. Hypertrophy is large thyroid hormone. What is the effect of pregnancy? Here again, the most common cause is autoimmune, but the condition is Graves' disease, where the patient has got antibodies against the thyroid-stimulating hormone receptor. Normal process may be toxic multidrug or toxic adenoma, but they are just common. Symptom features. Symptoms and signs of a normal pregnancy. It looks like hypothyroidism because of the anti-sympathetic activity. Specific features in the always looking for weight loss. Take significant for hypothyroidism. Someone with significant weight loss. Someone is got tremors. The persistent tachycardia. The heartbeat is more than 100, even at 100 noticed. In these patients are eye cells. Eye cells commonly can double more in 3 or 4 cells. And the exophthalmos upper surface. Divers opportunity output. Second thing is tendon infection. The leg is interrupted. This is polyester. Down increases and third one is the line. The leg is started coming down as it should. The patient looks down. This is called the one graph is. That is you have everyone putting more and shrewdness of the conjunctiva phimosis. Again, how to make a diagnosis is essentially my thyroid stimulative hormone is low, and if T4, any level of T4, after any level of T2 should go short. Pregnancy actually was improvement because I was doing this. Don't tell this stuff. That's left in the bush. If anybody impression with Kazar on note here, let's carry this. Slow favor. Immature judgment. Neonatal. I want thyroidism. Choice percentage antibodies it. First, the simple and past hypothyroidism in the lumbar. Always check for water and antibiotics. Monitor the heart rate and you are thyroidox. What is the name it is doing? Reply diet you are carnivore. Both are sensitive. Both of them are cost of the central. But propane thyroid does not have any effects on the baby. Carnivore has lot of maturation. Therefore, firstly, we should always prefer propane thyroids. You make sure that the T4 is the upper limit of normal, so that we know the patients are ventricle controlled. Meta markers are here. Suppose your TSH is going to be suppressive. Look at the T4 level. The T4 level, upper limit of normal. I told you not the normal values, so it is on every trimester, the T4 itself. First trimester, it should be 16, second trimester, it should be 15, and third trimester, it should be 14. For some patients, we discussed that they can have a surgical problem cause hyperthyroidism, but they have a toxic multinodular factor or toxic adenoma, which needs surgery during the second trimester. So what are the indications? Is surgery a must? Yes, it is a must. The patient has got mechanical symptoms like difficulty in swallowing, dysphagia, difficulty in breathing, failure. When we have a suspicion for carcinoma, thyroid, and the patient has got allergy to more than drugs, they cannot tolerate PTO, proper thyroid alcohol conversion. One important contraindication during pregnancy is never expose patient to radiology. One more complication which is mentioned in the books, but rare, is when the patient is optimally treated for hyperthyroidism, what happens is the patient develops thyroid storm. Where you have increased levels of thyroid hormones causing fever, pyrexia, confusion mentally, headache failure. The solution is of course that provided you control the patient's levels of hormones adequately during each trimester within the sterile limits. What is biochemical hyperthyroidism? This is a clinically apprehension is not having any of the features, but biochemically we can have TSH receptor stimulation and increase in the human chorionic hormone cycle. This occurs in two conditions. This is the first trimester, hyperemesis and molar pregnancy. So far, completes about the hyperthyroidism. I hope it was useful for the topic. Please like this topic, please comment, please share and subscribe. And you can also write to me about any other topics which you want to discuss with me in the future. Thank you very much. Bye bye.